Let's study retinal detachment. In retinal detachment, there is separation of the neurosensory retina from the retinal pigment epithelium, and there is collection of subretinal fluid in the subretinal space. Retina is not getting detached. Thus, there is separation of the neurosensory retina from the retinal pigment epithelium, and there is collection of subretinal fluid in the subretinal space. For the investigation, we need to do the indirect ophthalmoscopy, OCT, beta scan USG, and types of retinal detachment is the primary and secondary, rhegmatogenous and tractional exudative. Rhegma means there is break or tear or hole in the retina, and the retinal detachment may be due to break, retinal detachment may be due to traction or exudation. Pathogenesis of the retinal detachment. As there is syneresis, if there is syneresis means liquefaction of the vitreous. Normally, the vitreous chamber containing the fluid, vitreous fluid, is a gel, and in this there is liquefaction of vitreous means the gel is changing into the water. So it leads to posterior vitreous detachment. So some part of the vitreous is still attached to the retina, which exerts the dynamic vitreoretinal traction. Some part of the vitreous is get detached, but some part of vitreous is still attached, which exerts the dynamic vitreoretinal traction, due to which retinal breaks develops. This is the pathogenesis of the rhegmatogenous retinal detachment. So retinal break develops and fluid enters through the break and seeps into the subretinal space. So this is the neurosensory retina and retinal pigment epithelium. This is the subretinal space, and the fluid will enter in the subretinal space, subretinal fluid. So firstly, there will be liquefaction of the vitreous, which is a posterior vitreous detachment, and some part of the vitreous is still attached, which will exert the traction, vitreoretinal traction, due to which retina will break and fluid will enter through the break and seeps into the subretinal space. The causes of retinal detachment are the most common is the pathological myopia. When there is more than 6 diopter, more than -6 diopter, then it is the pathological myopia. Blunt trauma can cause retinal detachment. Retinal detachment can occur after the cataract surgery. Aphakia, if there is no lens, then vitreous and retina will be pulled. Lattice degeneration of the retina. Symptoms of retinal detachment are: there may be photopsia, which is the flashes of light. Floaters will be seen due to vitreal opacities. As vitreous are getting detached, this will be the vitreal opacity, and when the light will come, then this will block the light and black dot, flying dot like opacities will be seen. So the small black flying dot like opacities is seen. Photopsia is the flashes of light. Floaters, and patient complains of curtain falling in front of the eye. Loss of vision will be sudden and painless. In retinal detachment, there will be painless loss of vision, but it will be sudden. Signs of retinal detachment. Detached retina will appear grey, opaque. Retinal detachment extends till ora serrata. Detached retina will look convex. The Safford sign, there will be tobacco dust appearance. Relative afferent pupillary deflect. In long-standing cases, there may be retinal atrophy. Subretinal demarcation lines known as high water marks. Intraretinal cysts in long-standing after the 3 months, after the 1 year. Prophylaxis. Breaks most commonly seen in the superotemporal quadrant closed by the laser photocoagulation. if the patient has developed retinal detachment, but and in retinal detachment, rhegmatogenous retinal detachment, the break is seen most commonly in the superotemporal quadrant, which is already closed, which we close by the laser photocoagulation. For the treatment, if retina is mobile, then we do the tamponade, internal tamponade, in which we inject the pneumatic retinopexy SF6 or C3F8. Tamponade, we give the air or oil. Silicone oil is injected into the vitreous cavity, due to which the retina will move into its own place. Oil needs to be removed after around 8 to 12 weeks. We give pneumatic retinopexy and silicone oil. Silicone oil injected in the vitreous cavity, pneumatic retinopexy, SF6 or C3F8. SF6 or C3F8. If retina is immobile, which leads to the formation of membrane and scarring, then vitrectomy plus subretinal fluid drainage is done. The side effect of this silicone oil injected can be the hyperolian. If silicone oil leaks into the anterior chamber, it gathers superiorly. We can do the internal tamponade and external tamponade, in which we do the scleral buckling. If we do the scleral buckling, then the retina will move into its place. Linkoff rules locate the break in the retina. So this was about the rhegmatogenous retinal detachment. In rhegma means break. So in rhegmatogenous retinal detachment, there is break or tear in the retina. So the pathogenesis is firstly the syneresis, means liquefaction of the vitreous, which leads to posterior vitreous detachment. Then due to posterior vitreous detachment, some parts of the vitreous will attach to the retina, which will cause dynamic vitreoretinal traction. So retina breaks develops and fluid enters through the break and shifts into the subretinal space. Causes of the retinal detachment can be pathological myopia, blunt trauma after cataract surgery, and lattice degeneration of the retina. And the symptoms can be seen. Symptoms in the rhegmatogenous retinal detachment is the photopsia, is the flashes of light, and due to opacities, will be floaters, small black flying dot-like opacities. So floaters can be seen. Patient complains of curtain falling in front of the eye. There will be sudden painless loss of vision. Floaters, photopsia, curtain falling in front of the eye, sudden painless loss of vision. In the signs, detached retina will appear grey. Retinal detachment extends till the ora serrata. Detached retina will be convex. Saffir sign means tobacco dust appearance. Relative apparent pupillary defect. Long-standing retinal atrophy. Subretinal demarcation lines known as high water marks. Intraretinal cyst. For the prophylaxis, we can do the laser photocoagulation in the superotemporal quadrant. For the treatment, if retina is mobile, then we do the internal tamponade or the external tamponade. In internal tamponade, pneumatic retinoplexy, in which SF6 or C3F8 is used, and silicone oil is injected in the vitreous cavity, but oil needs to be removed. But if oil leaks into the anterior chamber, then it gathers superiorly, which is called the hyperolian. And in external tamponade, we do the scleral buckling. But if the retina is immobile, then there will be proliferative vitreoretinopathy, which leads to the formation of membrane and scarring. So we do the vitrectomy plus subretinal fluid drainage. Vitrectomy and subretinal fluid drainage. In tractional retinal detachment, there is no break, no photopsia, and no floaters. It occurs due to static vitreoretinal traction. Most common cause is diabetic retinopathy, retinopathy of prematurity, penetrating trauma, sickle cell retinopathy, present with Roth spots. There will be hemorrhage with clear center. Clinical feature will be loss of vision, gradual and painless, no photopsia, no floaters as in rhegmatogenous retinal detachment, does not extend till ora serrata, But in rheumatogenic retinal detachment, the it will extend till or acerata, and detached retina is concave. But in rheumatogenic retinal detachment, detached retina is convex. Exudative retinal detachment causes is most common choroidal melanoma, toxemia of pregnancy, Coats disease, VKH syndrome, and CSR. The clinical feature will be sudden painless loss of vision, convex detached retina, and there will be shifting fluid will be seen. As the patient will move, the fluid will shift. So there is total 3 types of retinal detachment: rheumatogenic, tractional, and exudative. In rheumatogenic, we see the pathogenesis, how the liquefaction of vitreous, vitreous detachment, then it will giving exerting traction, and the retina is breaking and the fluid is entering into the subretinal space. Then floaters occurs, cotton falling in front of the eye, photopsia occurs, then sudden painless loss of vision. Causes is pathological myopia, blunt trauma after the cataract surgery, degeneration of the retina. Signs is detached retina is grey opaque, retinal detachment extends till ora serrata, detached retina is convex, tobacco dust appearance is seen. For the treatment is retina is mobile. Then we give tamponade, internal tamponade and external tamponade. In external tamponade we do scleral buckling. In internal we do pneumatic retinopexy. SF6 or C3 F8 is used, and silicone oil is injected into the vitreous opacity. And if it's leak into the anterior chamber, it can cause the hyperolean. And if the retina is immobile, there will be proliferative vitreoretinopathy, which will lead to the formation of membrane and scarring. So we will do vitrectomy plus subretinal fluid drainage. In tractional retinal detachment, there will be no break, no photopsia, no floaters. No floaters. It occurs due to static vitreoretinal traction. The causes is diabetic retinopathy, retinopathy of prematurity, penetrating trauma, sickle cell retinopathy. There will be gradual painless loss of vision, no photopsia, no floaters. No, does not extend till ora serrata. Detached retina is concave. In exudative, causes is choroidal melanoma, toxemia of pregnancy, Coats disease, VKS syndrome, CSR. And clinical feature is sudden painless loss of vision, convex detached retina, and exudative. There will be shifting fluid. Will be exudate. So the patient will have shifting fluid, which is the hallmark of the exudative. This is all about the retinal detachment. You can find these notes on the Telegram, and the links are given in the description. Thank you.